That's the growing liver disease, and I like using the word growing, right? It's getting bigger and bigger. When I first started doing this 25 years ago, we didn't even know that it existed as an entity. We call it non-alcoholic fatty liver disease, and it's a spectrum. We estimate that 60 to 80 million people in the United States, out of a population of about 330 million, have non-alcoholic fatty liver disease. 2 to 4% of those people have what's called NASH, non-alcoholic steatohepatitis, which is defined actually by liver biopsy. Significant numbers of those have cirrhosis. So what we're seeing is more and more liver disease from this, lots of cirrhosis, lots of advanced fibrosis. These are patient populations that can develop liver cancer even in the absence of cirrhosis. The groups that are at highest risk are those people who are overweight and anyone who has type 2 diabetes. In fact, we tend to see fatty liver before diabetes will develop. This is the growing disease. We're getting better and better at diagnosing it, but we don't have any good treatments yet. The current treatments for fatty liver disease are diet and exercise with weight loss. And there are lots of clinical studies that we're participating in, and others are across the country, with newer drugs to treat fatty liver disease. But nothing is there yet. It's going to be another 5 to 10 years before we see things. But that's the new epidemic, right? The new epidemic is fatty liver disease. So if we have 60 to 80 million folks that have it, and the population is roughly 330 million, you're talking a quarter to a fifth of the population, is at risk, right? And especially high in children. We believe with diet and exercise and weight loss, it's reversible. But you really have to think about what you're eating. Eat smart, eat healthy, and exercise. Liver transplant is another miracle, right? If you think about 30, 40 years ago, it was somewhat experimental, now it's routine. We at Northwell are in the process of developing a transplant center. So we have a large liver center, a large liver program, and now we're trying to move to the next step, which would be to bring a transplant program to the catchment area that we serve. So it's early. We have a new building for liver disease that's opening up next month. We hired a world-famous liver transplant surgeon by the name of Louis Tepperman, who's bringing a whole crew of folks. So we're really on the rise. We're very excited by this program. We think that it will serve our patient population here very well because there's limited access to liver transplantation in our area currently. People have to go into New York City or leave the area to get it. And so we are truly in a growth mode. We're very excited about what we're doing. I think we're going to see great things in the future. Follow us because it's going to be a nice ride till we get to the first transplant, and then we'll be able to truly complete the circle and care for the patients. There is a real problem as regards to donation. For the first time, New York, just recent statistics show that there's a little uptick, in donation. But we have to educate. So part of the program as regards to transplantation is to educate people about donation. We're trying. That will benefit everyone across the tri-state area who's getting transplanted for whatever organ, no matter where they are. Hopefully we'll see all of the groups in our area come together to try to do that. And then for liver specifically, we can do other types of transplants. So there's a shortage of cadaveric, meaning someone has to die in order to get the liver, but there's what's called living-related donation. People can give a portion of their liver to someone else, and that actually works well. It's family members. Sometimes it's close friends, but it is usually family members. But then you can schedule your transplant, right? It tends to be done when people are less sick. It tends to be done not in the middle of the night. And so that's an approach that we're taking as we go forward, and our others. People think that if we cure all the folks with hepatitis C, no one's going to need transplants anymore. So two things about that. One is, unfortunately, if someone has advanced liver disease from hepatitis C, even if you treat and cure the hepatitis C, they're still stuck with the advanced liver disease. So they're going to need transplants. The number of new people with hepatitis C who need a transplant may go down, and we hope it goes down with cure, as you cure people earlier. Again, the argument for treating people before they develop cirrhosis, the anti-insurance argument, the importance of treating it now so they don't develop. So if we take those patients that we model out and we say that they're not going to need a transplant, we have the rise of fatty liver disease. And the predictions are in the next 5 to 10 years, that's going to be the leading indication for transplant. And there are other conditions, autoimmune diseases, hereditary diseases. So the number of people who need transplants will still be the same or go up. So just because we're curing one disease, which is great, doesn't mean the need for transplantation is going to go away. As of today, the answer to that is no. There's a lot of research being done about even thinking about transplanting hepatitis C livers into hepatitis C infected patients. We don't know yet whether or not you can safely take a patient who's been cured of hepatitis C and put their liver into somebody else. For example, if you had hepatitis C and are cured and remain with this antibody for life, you can't donate blood. I think only time will tell as we learn more. But cure is cure. There are discussions. Yes, there's a protocol, for that, but this is all early, and so I don't really want to comment much. It makes sense because HIV is so well controlled. If the donor can safely give, a portion of the liver, but again, these are all interesting things, and research has to be done. Trials need to be done, controlled, preferably in this country where we can really monitor and see before you can go out and make those recommendations to the population at large.